Okay, so good morning for those that are here at the ESGE Days 2024. Once again, congratulations to ESGE and to our community. And for those that are watching at home and that will see this, because this session will be recorded, we are very happy to discuss this topic on the role of gastroscopy for screening in Europe. Where do we stand? We have with us a panel that comes from the north of Europe, also from the east and some countries from the south. And of course, digestive cancers are still a problem in Europe and will represent a significant burden to our citizens. Specifically, gastric cancer will continue to represent a problem if we don't intervene, even though there are some signs of that we are more and more diagnosing cancer at an early stages, and therefore the survival of patients is improving during the last 2 decades. Maybe even without a screening population-based program, there are initiatives. Let's see where do we stand. Cesare, we published a position statement on the role of endoscopy for screening of digestive cancers. Is there a role for gastroscopy? What are the major, let's say, thresholds or the major points that we should consider to discuss gastroscopy as a screening procedure?
Yeah, thanks, Mario. I feel that as European society, we were very somewhat expected to publish this position statement because population-based screening for colorectal cancer happened here in Europe, for instance, not in America. And so it is Europe that deals with this idea of a population screening. But I guess that there are two somewhat postulates for an intervention at population level. The first is the clinical relevance of the disease. But for instance, for colorectal cancer, my risk to have a cancer in the next 10 years is 1.2%, according to the Nordic study. So I guess that some population here in Europe can have a similar magnitude of risk for gastric cancer. Okay, so this is the benchmark. But the second, very important one, is to have a test that is effective. And possibly this efficacy has to be shown in, I don't want to say randomized trial, but at least in very strong epidemiologic trials, studies, as the Americans did with colonoscopy. And this is maybe the problem with the gastric cancer. Okay. Because, of course, if you go in expert center, you can trust endoscopists to detect most of early gastric cancer. But would you do a population screening with a general level of community endoscopists that miss probably more than 50% of early gastric cancer? So the magnitude may be there in some places, but I guess, Mario, the issue is on the technique, whether it is endoscopy or it is non-endoscopy. Anyway, something that must be standardized across the population.
This is the perfect bridge. So we have a relevant disease. Probably we have different Europes in Europe, different settings where the risk may justify screening, but the problem may be with gastroscopy. Andrei, you were sharing the young talent group. You are leaving that position,
True.
but also you live in Romania. Gastroscopy, who cares about gastroscopy? It's the very basic procedure. Everyone learns that when they start. But then we have missing rates everywhere, even when we do a systematic review using the gold standard, the experts to compare with AI, and I will come back to AI, of course. How is it done in Romania? Is it because Romania is a high prevalence or at least an intermediate risk cancer for gastric cancer risk?
Yeah, it's true, Mario. Unfortunately, we don't have very good incidence and prevalence data from Romania, but it's obviously a disease that we are very concerned about. And just as you've said, everybody does gastroscopy, but it boils down to quality and to how the people that do the gastroscopy are trained. And we know from studies, even from high prevalence regions like Japan, where you have a screening and surveillance program, that even experts who are trained to look for these early gastric cancers do have a high miss rate, a moderate miss rate. And maybe AI can mitigate some of that, but in the end, it comes down to the endoscopist performing the gastroscopy. And you're not going to look for that early gastric cancer if you don't know about it. So, of course, we only find what we look for, and we only look for what we know is there. And I guess that training should be more focused on this particular problem.
Yeah. So can I understand again from Cesare and you that eventually, if we decide for gastroscopy, there is still a room for definitely improvement in the quality metrics, because we have been developing that for colonoscopy. ESGE was quite pioneering, also pushing some concepts on the quality of gastroscopy, but we still have to improve.
Of course, I think there's a long way to go, and I think that we should look at training for this, because every gastroscopy that we perform, even in open access, should be looked like an opportunistic screening. If you do a good gastroscopy and you're trained to look for these subtle lesions, then you're going to have an impact at a populational level.
Of course. And moving to AI, of course, I'm looking to my left side again. We published a manuscript recently. Can you shortly address that manuscript that alludes to the fact that if we use AI, we can be more cost effective?
Yeah, so there is an somewhat unexpected efficacy from AI in apparently eye cancer screening. And this is that AI can address not only detection, but also the navigation, something that in colonoscopy we cannot do. So AI can tell you if you explore all this stomach. When considering the high miss rate of early gastric cancer, and when assuming a very high sensitivity for early gastric cancer, for instance, I don't know, 90%, then Helmut will tell us if this is reasonable. Then AI for gastric cancer detection is cost effectiveness given definite prevalence of disease. In my view, Mario, it makes much more sense AI for gastric than for colon. Yeah. Because in gastric we are dealing with cancer. In colon we are dealing with polyps.
Yeah. This message is quite important, of course, that it's almost a paradox. We defend gastroscopy as the perfect gold standard for the stomach, but the a priori chance of finding a cancer is so low then the negative predictive value is very, very high. But the chance of missing a cancer is also not despicable. It's up to 10 to 20% in some series. What Helmut, do you know about what the providers, the main companies are doing in that field? Because we have several systems for the colon. You have been involved as a researcher for the esophagus. Do you know something that we probably can wait from the companies in the next months?
No, definitely not. It's too early. I think AI will definitely improve our detection rate. So talking about screening and cost effectiveness is a main key in prevention. In each guideline, Barrett guideline, gastric guideline, we always recommend screening is not cost effective, but we have to look at the whole upper GI tract. So we look for Barrett, we look for squamous cell cancer, we look for gastric cancer, we look for cancer in the hypopharynx. So we need to be trained that we want to find, and in Germany we have 60,000 colon cancer, and we have 40,000 cancer in the upper GI tract. Yeah. Only 7,000 esophageal cancer. So let's put everything together. This is one way to get cost effective. The next step is to find high-risk patients. Not everybody needs a gastroscopy, so we need, and this is what we got in our grant, we need a risk stratification, and at the end, the quality. The quality, how can we improve quality? And this is the place for AI. I think if companies, and with our tool, we could show in videos that an expert will not benefit from AI in Barrett, but a non-expert who does not see every day 10 Barretts, he will find more Barrett lesions, Barrett neoplasia. This is a hypothesis now based on videos, but I think this is the way to go in the next couple of years. Yeah. Yeah.
And of course, since 20 years ago, the speech has changed, because 20 years ago we were still struggling on saying to the community that you should watch to the pink stomach that stays in between esophagitis or Barrett's and the duodenal ulcer. So everyone is paying attention, also the EU. And Manon, we share some meetings. You are a co-researcher in 2 European-founded grants. Can you let us know what is out there and what we are trying to achieve with those 2 main projects, namely TOGAS?
Yeah, so the interesting thing is the thing where we're now talking about and how do we go forward or move forward with early detection of gastric cancer and which screening strategies should we take in different countries. So that is addressed. It's called the TOGAS and the AIDA, so both European grants where different countries in Europe are participating, also with different preferences of H. pylori and gastric cancer. And in AIDA, the artificial intelligence is actually playing a central role in trying to define or calculate a prediction model, is who is at risk, but also a central role in imaging, in detection of the precancer lesions, but also the early gastric cancer. And also AI is used for the pathology to accurate diagnose intestinal metaplasia or dysplasia. And in TOGAS, different screening strategies are assessed, like H. pylori screen and treat, or should we go for an upper endoscopy combined with colonoscopy for those who are already have a FIT positive and go for a screening colonoscopy, or those who have a surveillance colonoscopy also get an upper endoscopy. And the last screening strategy is screening for H. pylori combined to pepsinogen to detect not only the H. pylori but also atrophic gastritis, in short.
No, again, it's an important disease. We lack training programs. There is another initiative from the EU, a joint action, where we will deliver standardized ways to deliver courses for gastroscopy. We may join forces with we may be synergistic with other programs. And Helmut alluded to the fact that if we decide for gastroscopy, either improving the a priori modeling for selecting patients throughout non-invasiveness tests or directly in all the population that is submitted to colonoscopy, it may be cost effective. We have a model that we published a couple of years ago. We've shown that AI can improve. What other initiatives are there? In Romania, is there any initiative from the governmental or any research group that is working on screening? Italy, Germany?
Unfortunately, I'm not aware if there is a concerted effort to do screening for that. We've just started screening for colorectal cancer, so we're some ways away from that. But I think that the most important part remains to do a good gastroscopy, to have a clean, to start thinking about gastroscopy the way we think about colonoscopy, and have a clean stomach, and have a good inspection time, and respect those quality parameters that the ESGE has put forward, photo document, and then look at the pictures and maybe also detect something that you weren't looking for initially. But unfortunately, so far, there hasn't been let's say, a united front on this, on the gastric cancer problem, and this is why discussions such as these, I think, are very important.
Okay, so let me just pick this as one of the potential final messages, that is, regardless of what, let's say, the structures or the governments are pushing or you have in your community, you should perform screening or opportunistic screening in all the gastroscopies that you perform. Yeah? Of course, depending on the a priori risk, but you should do it, okay? In Italy, any initiative?
So first, in Italy, expertise follow disease prevalence. For instance, we have 2 regions in North Italy with a high prevalence of gastric cancer. And I must admit that opportunistic screening in this region is working very well because the regional system retrained its endoscopies. So there is also a connection between competence and disease prevalence, as you said, about the Barrett. So the same for gastric cancer, atrophy, etc. But also in Italy, research is moving for AI in region at high risk of gastric cancer. So I feel that in the mid and long term, clinical practice will follow research. If we show that AI is effective in a region at high risk of gastric cancer prevalence, it is likely that AI will facilitate the implementation of screening programs. But first, we need to show to be effective in a clinical, large, randomized trial, as the Chinese did. It's not impossible. We can do it. We need to be patient, but we can do it.
Yeah, but this is, again, the second important message is that even if we wait for AI to improve our skills, the number needed to include in the study will be very large. We are estimating this as we speak, but it will be above 1,000 for sure in each of the arms. And about your grant in Germany, we know that you won a recent grant.
Yeah, this grant finally was accepted this year. We were struggling for years to start with a program combining upper GI screening with lower GI screening, unselected, which is maybe not cost effective. So we changed our strategy. So we do now risk stratification. And this will be a first step now in Germany to combine lower and upper GI screening with risk stratification. And hopefully, including also AI, what makes this screening program so attractive? In Germany, we have roughly 22,000 gastric and esophageal cancer. 10% are candidates for endoscopic treatment. Mm-hmm. We don't treat 10% in Germany. There are still too many surgical procedures on the one side. On the other side, if you look in Japan, the number of endoscopic treatment is much higher. It's 50%. So we can increase, and this saves cost as well. Yeah. So this makes, hopefully, the insurances interested in our project and to support this idea.
Yeah. Actually, I addressed Germany, but we have also in our audience some other German centers with other initiatives like TOGA. So I think the message is, and you can probably try to understand within your community, if there are other initiatives. For instance, in Portugal, we have in our center, we also participate in this consortia, both AIDA and TOGAS, and by participating in those studies, other centers approached us to say, can we also provide some data? Can we also standardize? And even by standardizing, as we are standardizing for trials, well, we know this from clinical research, probably the quality in our community will improve. Any last comment, Manon, to our community as a challenge, as a summary?
No, I think you actually have pointed out the challenges is performing good quality and upper endoscopy that also would save lives. And I think the research, the grants would help us to better identify which strategy is the most cost effective. And maybe it also depends on which country you live in. It's also important, for example, for participating in such a program, because that is the main thing. You need to participate if we want to do something about gastric cancer.
Any final remark, Cesare?
I agree with Helmut that probably the next realistic target is to increase the proportion of upper GI cancer that can be treated endoscopically. I think this is a win-to-win for Endoscopy Society, but also for the community, for the cost, etc. This may be a really realistic goal to be achieved in the next future.
Andrei?
Well, I just urge everyone to check out the very interesting sessions on early gastric cancer that are going to be available the next days, because I think you'll learn a lot, and that's important for training for this part.
Very good point.
Helmut, one last comment.
Well, I think this Spotlight Studio was ideal to give this information to the audience, to the participants, and I think it was a clear message. Screening in the upper GI tract is still underrepresented in Europe, and we should go forward to improve.
Yeah. And my last comment, even though the topic was on gastroscopy, I think what somehow we alluded was to improve the a priori chance of finding a cancer, eventually throughout non-invasive tests like we do for the colon. So I think this session probably can be repeated in 5 years, and we will see how it goes with an improving quality of gastroscopy, but meanwhile selecting better the patients to whom we provide gastroscopy. So I think this is the perfect way to finish this session, and I hope that you will enjoy, and hopefully you can contact all the centers around and push gastric cancer early diagnosis finally. Thank you.
Thanks.